Well, now I would like to introduce Dr. Addie Hirshberg for our next presentation. She's an assistant professor of clinical obstetrics and gynecology at the University of Pennsylvania Perelman School of Medicine, where she specializes in maternal fetal medicine with extensive experience managing and teaching high-risk obstetrics. Her areas of interest include hypertensive disorders of pregnancy, quality improvement, severe maternal morbidity, labor and delivery, and prenatal diagnosis. As the director of obstetrical services at the hospital of the University of Pennsylvania and the hospital physician lead for the Women's Health Service Line and Quality Improvement Committee, Dr. Hirshberg focuses on quality improvement and research initiatives aimed to improve outcomes in our pregnant and postpartum population. As a result of interests and goals, she has co-developed Heart Safe Motherhood, a text message-based postpartum hypertension monitoring program used throughout Penn Medicine. Help me welcome Dr. Addie Hirshberg to present Approach to Diagnosis and Management of Postpartum Hypertension.
Hold on one second while I just figure out how to share my screen again. Can you guys see my slides?
Yes.
And the regular view is good? All right. So good morning. Thank you for having me here virtually. I'm sorry I can't be there in person. I'm here to present today about management of postpartum hypertension, specifically texting for improved compliance and outcomes in this area. I'm going to spend a little bit of time in the beginning just talking about general hypertension, and then sort of talk a little bit about Heart Safe Motherhood and other remote monitoring programs. And I have no disclosures. So as a high-risk obstetrician, I see a lot of patients who have pregnancy-related hypertension. Older data suggests that this complicates 10% of all pregnancies, and newer data suggests that about 30% of patients might actually be discharged with a diagnosis of pregnancy-related hypertension. It is a leading cause of 7-day obstetrical readmissions and is responsible for about 20% of the 700 maternal deaths that occur in the United States every year. And we all know that the maternal mortality rate in the United States is higher than any other developed country, and the trend is heading in the wrong direction. So anything that we could do to move the needle in the right direction is a step in the right way. As you know, we do a really good job, or I should say most of us do a better job at dealing with antepartum or intrapartum management of hypertensive disorders. But one of the things that I want to make sure that we sort of go home with today is that delivery is not the cure for preeclampsia, as people used to say, and people remain at significant risk in the postpartum period. And some studies suggest that nearly 75% of maternal deaths associated with hypertension occur after delivery. Nearly 40% of them occur more than 48 hours postpartum, which is often after obstetrical discharge for someone who, let's say, has like an uncomplicated vaginal delivery. And the highest risk for postpartum stroke is during the first 10 days after hospital discharge. So a lot of us are sort of stuck in this situation. How do we keep our patients sort of safe, but also don't keep them in the hospital for these prolonged periods of time when they're still at risk? And so instead of telling sort of my trainees and patients that, you know, delivery is the cure, I really tend to focus that delivery is the immediate treatment of preeclampsia. And really, I saw this editorial once, those of you who, you know, like are baseball fans, it ain't over till it's over. You're still at risk. And that is exactly what the Preeclampsia Foundation has, these Still at Risk campaign, that postpartum preeclampsia is an entity. It can happen to any patient, not just during or, you know, before delivery, but up to 6 weeks after a baby is born, with a lot of risks. And so, you know, this sort of discharge information that is supposed to go home with all patients is a reminder that delivery isn't a cure, but often a treatment, but patients still remain at risk after delivery. As far as diagnosis of postpartum hypertension, it's sort of the same algorithm as, you know, antepartum. You have the spectrum of gestational hypertension, preeclampsia, eclampsia, and HELLP syndrome. And so the definitions don't really change. patients who remain hypertensive up to 6 to 12 weeks postpartum may then go on to develop chronic hypertension, but it's the same parameters as we do antepartum as far as diagnosing someone with postpartum, pregnancy-related hypertension. I don't think we have to go into all the definitions today, but a lot of the same, anyone who has new onset blood pressures over 140 over 90 in the postpartum period, or severe range blood pressures will sort of be diagnosed with one of these disorders. As far as management, I also don't want to spend too much time talking about how to treat it, but this is a nice algorithm from an article out of AJOG several years back that sort of talks about what we do for patients with persistent hypertension postpartum, if they're just hypertensive, if they're hypertensive with neurosymptoms, and also to look out for some of the sort of more rare causes potentially, like thyrotoxicosis and cardiomyopathy that happen after delivery, but sort of making sure that patients who are severely hypertension get the treatment with antihypertensive medications, potentially get treated with magnesium sulfate, and then at some point, hopefully be able to then go on and stay home again, because we know there's a lot of benefits to also being home with newborns as far as bonding and breastfeeding and all the other sort of great things that can happen. Why are people at risk for postpartum hypertension? Well, we know that there's excess total body water. A lot of that fluid that is increased during pregnancy then gets mobilized into the interstitial and extravascular, into the intravascular space from the interstitial and extravascular fluid. There's impaired sodium excretion, there's suboptimal renal function. I have NSAID pain medication up there. I will say that that is more a historical thought. More and more studies have come out to say that NSAIDs do not increase blood pressures and should be given to patients, and are definitely preferred over narcotic medication, even in patients who have a postpartum hypertension. But previously that was thought to be a factor for sustained hypertension. And I keep it up here because it comes up a lot in conversation, even though it is definitely something that should continue to be used as a pain medication in these patients. And given the increased focus on postpartum hypertension, ACOG had a task force and continues to put out recommendations that patients who have a hypertensive disorder of pregnancy should get their blood pressure checked at least 72 hours postpartum, and again, 7 to 10 days after delivery, sooner if they have symptoms. And again, this is to highlight that peak blood pressures occur 5 to 7 days postpartum, and those first 10 days are the highest risk of stroke. And so that was something that was put out there, but not with a lot of guidance as to how to do it. I think this was in like 2013. So I like this sort of blood pressure trajectory arrow. Again, the peak blood pressures happen 1 week after delivery, and some people go on to still have hypertension through 12 weeks. But the early postpartum period is the highest risk of stroke and maternal mortality. So it's difficult to predict who at discharge is at greatest risk of persistent hypertensive disease, worsening disease, de novo preeclampsia. And when ACOG put out these recommendations, and then again in 2018, when they put out the committee opinion on optimizing postpartum care, again, no real guidance on how to put this into practice. Our experience previously at our institution, and still continues in a lot of places, is that many people have patients return to the office for an in-person blood pressure check in this time frame. Some patients have the luxury of having visiting nurses to obtain a reading at the patient's home. But in-person blood pressure checks previously were sort of the mainstay, and continue to be so in a lot of places. And so the recommendations came out. We had actually nothing in place for blood pressure checks. And so we decided to create a blood pressure check clinic. And every patient that had a hypertensive disorder of pregnancy was asked to come back to the hospital, in this 72 hours, if they were discharged before 72 hours, which wasn't something we were doing previously, but even in that 7 to 10 day window, they would come back for a blood pressure check. And you can see that our show rates were pretty terrible. It remained on average, less than 50%. And later on, I'll show some slides about differences by race, but 34% of patients would come to these visits. And we were seeing a lot of readmissions even prior to the time this visit was scheduled. So having a visit at 7 days postpartum sort of wasn't enough to catch patients when they were severely hypertensive, many of which were asymptomatic at the time. And we tried various things. We tried alternate staffing models. We had patients even potentially just walk in when it works for you, understanding that the postpartum period is very busy. We had phone reminders, text reminders, and I mean, you can see, despite all these things, our show rate actually got worse over the years. And when it's looking at ACOG recommendations for blood pressures at 2 time points, I mean, we weren't meeting this on any patient. So no one was getting it at 72 hours and again at 7 to 10 days postpartum, unless they were sort of still in the hospital on day 3 and came to their visit. But that was pretty unlikely. And so this was really frustrating to me as a MFM. I was frustrated with readmissions from a quality perspective. It wasn't patient-centered. And like understanding there were so many barriers to in-person visits, you know, erratic newborn feeding schedules, recovery from C-sections, going to the pediatric visit, just transportation, having to pay for parking, for what these people perceived as a 5-minute blood pressure check, and often they felt fine. Like, it was understandable why many patients weren't coming to these appointments, but also very frustrating that, you know, some of them were experiencing complications. And so we really wanted to think outside the box and figure out how can we get this blood pressure information and overcome a lot of these barriers. And sort of our initial like aha moment was, you know, everyone was always on their cell phones in our ultrasound unit. Everyone was always on their cell phones in the waiting room. And so we were going to say, like, can we take advantage of this sort of reproductive age population that has high access to cell phones and unlimited text messaging, and maybe find a way to monitor blood pressures from them. And so we came up with this idea for Heart Safe Motherhood. And we said, you know what, if we send patients home with a blood pressure monitor and then text them to check their blood pressures, can they reliably check their blood pressure accurately and text us back the result? And can we safely keep them at home? So before we went and developed this like major program, we did a pilot, and we got a nice grant from an internal accelerator innovation program. And we performed a series of 7 pilots using a PDSA cycle, testing our assumption that if we sent them home with a blood pressure cuff and texted the blood pressures, we would get the information that we needed. We had various iterations. In this early process, I single-handedly sort of texted patients twice a day to check their blood pressure. They would respond, and then I would sort of give feedback to the patient based on the blood pressure and figure out best next steps. And we interviewed patients at each of the iterations to figure out how to get to the point where we got our maximum patient engagement and most blood pressures back. So we just sent basic reminders. We tried to see if we send them information about preeclampsia, would that increase the likelihood of them texting back a blood pressure? If we included a baby name, if we let them just choose the time to text us on their own, all these sorts of things that we thought might help patients be most engaged, having even a buddy system where we sent a reminder to an identified support person to make sure the patients check their blood pressure, and sort of using patient interviews and their feedback ultimately came up with like sort of a final plan, which to our surprise was that all of these sort of cycles 2 through 6 didn't really improve anything, and just simply sort of focusing on the discharge instructions and then sending them generic texts, you know, at standard times was very simple, and patients really liked that. And so you can see here the patient engagement, the number of patients who were meeting ACOG recommendations. So blood pressures, you know, we used post-discharge day 1 to 2 as a surrogate for 72 hours, 5 to 7 for 7 to 9 days postpartum. And you can see that sort of the engagement was pretty good with the basic function. The patients sort of did respond a lot to the snooze function and countdown, but didn't think it was sort of ultimately like super helpful. And so we ended up sticking with some sort of variation of our basic text message reminders. And so you can see that we got to close to 65% when we sent patients home with a blood pressure cuff and texted them in meeting ACOG recommendations for the blood pressures at the 2 recommended time points. So the other thing that I want to mention is that during these time frame, actually, patients were also asked to come to their in-person visit, and only 15% of the patients came to their visit. So they told us they appreciated the convenience of text messaging. This was something that they felt safe with, and really enjoyed engaging with this. And so it was really promising. And so understanding this and knowing that it's not feasible for a single person to sort of constantly text patients back and forth, we wanted to scale this into an automated program. And with that, our pilot then turned into what is currently the Heart Safe Motherhood program, which is remote blood pressure texting and monitoring for 10 days after discharge. So you can see here, you know, we give patients a blood pressure cuff in the hospital, although many people now have them antepartum from COVID still. We send them text message reminders twice a day to check their blood pressure. And we have a platform that runs through Rita Health, which is a pen-based research platform in which all of the blood pressures come in and automatic feedback is pushed out to the patient. And so I'm going to show you in more detail what that looks like. So here's an up-close view of what the patient's phone would look like. You get a good morning text, please check your blood pressure, text it back. They actually have an automated cuff. It's not wireless, it's not Bluetooth. That we thought was not generalizable to our population. And we found that having the patients actually have to text in the number themselves was not a barrier. And then based on what they put in, they get automatic feedback. So the platform is smart enough that it can, separate into 3 groups of blood pressures. So normal, mild, and severe. And they get feedback. Your blood pressure looks great. Your blood pressure looks okay. And if it's severe, they're notified that it's high. We ask them to recheck it. And a provider is alerted via text message that patient X had a severe blood pressure. And that prompts us to call the patient and figure out next steps based on a variety of clinical factors. And this is what the provider would, sort of get on their phone if they were covering. For safety purposes, and also to make sure you can trend blood pressures, we have this on the platform. You can see all the blood pressure texts that come through. And it's also easy to look in a color-coded fashion by patient. We look at trends. Green means good, yellow means mild, red means sort of, those are the ones that we get the severe alerts for. But sort of, you can see if any intervention is sort of helping. So if we started a medication, are they now more in the green zone? Which patients are over 150, over 100 and can benefit from starting a medication, but it didn't trigger an alert. So we review the sort of platform every day to also find the patients who don't need immediate intervention, but could in theory benefit from some sort of intervention. So this is how the program looks. That's how we set it up. And as part of this, we standardized our inpatient and outpatient hypertension protocols. We made sure we made it very clear who was eligible for the texting program. We improved our discharge preeclampsia education. And then we also we created program-specific patient information videos and pamphlets so that the nurses could review how the program works. And so having this all in place, it was still really hard. A lot of people were still very uncomfortable with the idea of sending patients home with higher, stable for discharge, but with higher blood pressures, or, skipping office visits altogether. Some of our providers were hesitant to use telemedicine pre-COVID to monitor patients who were at such high risk. And so we decided to do a study comparing traditional office-based blood pressure checks to our text-based remote monitoring program. And this was published in BMJ Quality and Safety in 2018. And I'm going to go through some of the findings now. And again, the key here was to increase the likelihood of adoption of what we thought was an innovative intervention and what we were comfortable with, but really needed to make sure that everyone else was comfortable having their patients enroll in such a program. And we really were hoping to change the standard of care. So this, it was a randomized controlled trial, and I'm going to talk about the secondary analysis later on. It wasn't blinded, so you knew who was randomized to text. And it was over the course of a 6-month period, and all women with pregnancy-related hypertension who delivered at the hospital of the University of Pennsylvania, where I predominantly work, were enrolled in the study or eligible for the study. We included postpartum patients with all forms of hypertensive disorders of pregnancy based on ACOG criteria that was diagnosed prior to delivery or during delivery admission. So the key here is that the program, as we're going to talk about right now, is only for patients who are already diagnosed. So looking for patients who had persistent hypertension, not trying to catch sort of de novo preeclampsia postpartum. We included singleton and multiple gestations. They, at the time of the study, had to be able to speak and read English because that's what the text messages were in, although since then we've brought in the languages available. And in order to not have any sort of financial burden on the patients, they already have to have access to a cell phone with unlimited text messaging capabilities. And patients randomized to usual care had their office-based in-person blood pressure check. It was a 4 to 6 day postpartum visit for a nurse blood pressure check provided at discharge, which is what we, at the time of the study, had been at. And then the nurses and the doctors at the visit would escalate care or initiate blood pressure medications as indicated based on what we had an outpatient hypertension initiation protocol that was standardized. Those who were randomized to the text-based surveillance got the blood pressure monitor in the hospital. They received the twice daily text reminders to check their blood pressure. And they either received immediate feedback for the algorithm. Well, they always received immediate feedback, and then if there needed to be escalation of care and initiation of blood pressure medications, that was based on the same algorithm that the outpatient office was using. And we had 3 specific aims of the study. So we wanted to see if text-based surveillance would increase patient engagement, which we defined as a blood pressure in the first 10 days after discharge. We wanted to look at the percentage of patients who met ACOG guidelines for blood pressure ascertainment. And then we also looked at a bunch of secondary outcomes. How many patients got started on a blood pressure medication after delivery, how many patients had to go to the ER, how many patients were readmitted, and what the patient satisfaction was with the remote blood pressure monitoring program. And we also surveyed if this helped, improve future health awareness, understanding the long-term risks of preeclampsia. And so these were our results. We had 206 patients consent, 103 patients were randomized to each arm. It was a randomized study, so there were no differences in age, race, insurance, gestational age at time of diagnosis. And I think it's important to highlight that 40% of our patients had severe hypertension. So this was a very high risk population that we studied. For our primary outcome, which was a single blood pressure obtained within 10 days, 44% of patients in the office arm attended their visit, compared to 92% of patients who texted in a blood pressure reading. So that was statistically significant. And we also found a decrease in our hypertension readmission rates. We had no readmissions in the text messaging arm, and we had 4% in the traditional office visit follow-up. There was no difference in outpatient hypertension medication initiation. There was no difference in emergency room visits that didn't result in a readmission. And we did see an increase in attendance at the postpartum visit. And we don't 100% know why, but our thought is that having them engage in their health, for, at least a week or so after delivery, just generally increased the patient engagement and empowerment and resulted in increased attendance at their postpartum visit. So given that it's Black Maternal Health Week, I also wanted to spend some time talking about disparities in hypertension and how this program impacted that. So we know that, Black women are 3 to 4 times more likely to die from pregnancy-related causes than white women, and are more likely to suffer a severe morbidity. Sorry, my automation is going crazy. We know that Black women with preeclampsia are 3 times more likely to die from disease and are at increased risk of cardiac arrest and heart failure. And this has been shown when we look at racial disparities in preeclampsia-related deaths in the past 50 years. So we haven't done a great job at sort of eliminating the disparity. So this caused us to also look at how did this program impact our racial disparities in blood pressure ascertainment. So we went back and we looked at our blood pressure check visits from our clinic, and we analyzed things by race. And you can see that there was a disparity in in-person attendance even. So the show rate was on average less than 50% for non-Black patients and less than 25% for Black patients. And that too didn't improve with any of the strategies that we had implemented to try to make it easier on the patient. We know, again, that there are barriers to in-person care, many of which I mentioned before, and a lot of these barriers disproportionately affect Black women. And so even more reason for us to sort of see, did text messaging reduce some of these disparities? Did it help overcome a lot of these barriers that resulted in the difference that we saw in our in-person visits, and thus the ability to get blood pressures after delivery? So that was our goal of our secondary analysis. And again, office visit attendance versus blood pressure texted, and we compared the outcomes between women self-identifying as Black and non-Black. And so again, initial study had 206 randomized with 103 patients to each arm. The majority of the patients in both arms were Black, 71% in the in-person office visit and 66% in the text surveillance. This is a table that demonstrates the demographic characteristics. I wanted to break them down a little bit more by race. Black women were more likely to be younger, were more likely to have Medicaid insurance, they had a higher BMI, they were more likely to be multiparous, but the gestational age and the severity of the diagnosis was no different. So all things otherwise, the severity of the disease was not different. And again, about 40% of patients have severe features. So the highest risk patients were still enrolled in the text-based program. Most patients in our hospital are discharged on postpartum day 2 or 3. Black women more likely to be discharged from the hospital on an oral hypertensive medication, and we're less likely to be breastfeeding at discharge. So just a few interesting things to highlight. So here are the results. So 70% of non-Black women attended their office visit when they were part of the study, which was already higher than previously, but 91% of non-Black women texted in at least one blood pressure value. So text messaging improves the blood pressure ascertainment compared to usual care in non-Black women, and that was statistically significant. When we look at Black patients, only 33% of Black patients attended their office visit, whereas 93% of them texted in at least one blood pressure reading. So again, text messaging statistically improved blood pressure ascertainment compared to our asking them to come to the office visit. When comparing within each trial arm by race, again, non-Black women, when it came to office visits, were more likely to present to care, and that was statistically significant, 70 versus 33%. But there was no difference in blood pressure ascertainment in the texting group by race, with equal blood pressure ascertainment at over 90% in both Black and non-Black women. Great. And while we found that both race groups had significant improvement in blood pressure ascertainment in the texting arm, the magnitude of impact was significantly greater in Black women, and this resulted in equal blood pressure ascertainment in the text messaging arm, suggesting that this can eliminate racial disparities in blood pressure ascertainment amongst Black and non-Black patients. So that's great. What about other outcomes? So within the text messaging group, there was no difference in ascertainment in blood pressure at the 2 time points as recommended by ACOG. And so the disparity that we saw previously was no longer evident with equal blood pressure ascertainment amongst both races. This is, I think, really important. 20% of Black women who texted or attended their office visit were started on a new antihypertensive medication or had a dose adjustment after discharge. And as there was no difference in the percent of Black women who required intervention after discharge by trial arm, text messaging and increased blood pressure information that we received would have likely led to medication initiation in 10 of the 49 Black women who missed their office visit, providing an opportunity to intervene sooner and potentially decrease morbidities associated with continued hypertension after delivery. So the conclusions from this were that most sites are not meeting recommended guidelines for postpartum blood pressure ascertainment, despite the recommendations from ACOG and other societies. ACOG does support alternatives to in-person assessments, and I think there's been more comfort recently with using telemedicine and home blood pressure monitoring. COVID, I think, really helped that, not only get the supplies for patients, but also general comfort with telemedicine, even in pregnancy. Text messaging is an innovative way to equalize and engage women of all races in the postpartum period, and may help reduce postpartum maternal morbidity and mortality in Black women, and as a means of reducing disparities in maternal and long-term health. And I think more and more we're seeing text messaging being used not just for hypertension surveillance, but also potentially exploring, breastfeeding support, post the 4th trimester, depression screening, and other just patient sort of information after discharge from the hospital, during pregnancy, but also postpartum. So what are the advantages? A lot of people are still nervous about remote monitoring. What are the advantages of doing home blood pressure monitoring, and what are the limitations? So it's easy to use. I think we've seen that most patients are comfortable putting the blood pressure monitor on after they learn how to use it. And a lot of the cuffs now are just automated. So you put the cuff on, you push the button, and it gives you a reading. And it's relatively low cost. The cuffs that we use are about $20 to $30 per person. And again, insurance started covering things a little bit more recently, but still overall low cost. It empowers the patient, which I think is key here. They have the opportunity to check their own blood pressure. We also found when we interviewed patients, they said, yeah, everyone in my family uses my blood pressure cuff, and my sister gets to use it now, and all these sorts of things. And so it sort of allows for other people also to check their blood pressures and empowers their family members as well. It reduces office visits needs and removes barriers to the in-person visit that we talked about before. And I think importantly, what this has also helped with was provide data for blood pressure trends and research. So instead of just having a single blood pressure from the office visit, we now have blood pressures, 1 to 2 blood pressures a day over 10 days. Some of our research studies are extending the time period even further to see like what does actually happen to blood pressures after delivery. Who of these patients is actually at risk for developing persistent hypertension? Is that impacted by race? Is it impacted by mode of delivery? Is it impacted by breastfeeding? And really sort of looking at trajectories after delivery and seeing, can we further tailor this down or further educate the patients at highest risk and potentially intervene in those patients in a different way? So those are all of the advantages. What are the limitations? So there aren't a ton of validated cuffs in pregnancy. Whether are the pregnancy cuffs, the same accurate and or the same accuracy for the postpartum patient is still tough to know. And can we trust these readings? We definitely have a bunch of patients that, especially before delivery, who check their blood pressure at home, say, oh, I had a high reading at home, and they come into the office and it's not that high. And so, is that happening postpartum? It's definitely possible, but we often see that the blood pressure readings are falsely elevated and not low. And so we'd rather patients come in if they think it's high, and sort of be overly cautious and have them come in and get an in-person check if they need it. There's really lack of guidance for optimal frequency and timing. Is what we do twice a day for 10 days the best? No, we don't know. Would we get enough information with once a day? Should we do it for longer? I think those are all questions that still need to be answered. It does rely on a pretty significant infrastructure support on the receiving end. You need to have a system where you have nurses in the hospital or providers who are enrolling the patients in the platform, making sure they're receiving the text messaging, have someone on the back end receiving the blood pressure information, be willing to manage how the patients and call them, and different places can do that differently. We'll talk about different ways to sort of do it in a little bit, but it does require a lot of structure and setup, but once it's implemented, is pretty, seamless in my opinion. And then obviously the limitation of reimbursement, which I'm going to talk about a little bit at the end though, but the platform for us costs money. On the patient end, it's very cheap, but like even just the time to review the blood pressures, to call the patients, how do we get reimbursed for this? And would that even cover the cost of the cuff and the platform on the back end to make it sustainable? We initially started with the grant. We continue to get grants for other aspects of the program, but fortunately for us, our department now funds the blood pressure cuffs for patients who don't have one ahead of time. They all go home with one. And the people doing the work are doing it out of their clinical time. But we're working on ways to sort of further get reimbursed for our time and the care that we're providing. There's still a lot of questions about self-measured blood pressure monitoring. I like this who, when, how, why slide, because there's really no right way to do it. Again, I think we're still all trying these things out. I just sort of showed what we do, but there are other programs out there. Some just do high-risk patients. So like I said, this program is for patients who have a known diagnosis. We also started a less frequent, less intense blood pressure monitoring program for patients without it. So they only get every other day for the first week, and then space it out afterwards to see if we can catch de novo preeclampsia. We have a centralized model where maternal fetal medicine manages the blood pressures, but we've also implemented in other places where the blood pressures get sent to individual practices who manage their own patients. Does a nurse respond to the blood pressures first, or is it a physician? Is it a generalist physician versus an MFM? Again, I said for us at my hospital, I do it as an MFM, but ones where it goes to the individual practices, the generalists are sort of managing the blood pressure. And some places even have cardiology or nephrology doing the blood pressure management after delivery. So, we can receive the information. The question is who we're asking to get the information from, and then how are we working on it from the receiving end? When do we do it? So again, this is a postpartum program that's daily. There are many places now who have antepartum blood pressure monitoring that happens less frequent, but self-measured blood pressure monitoring is being used in that scenario. I talked about how ours is just simple text message based because of our patient population, and we thought that would make it the most generalizable, but there are automated monitors. There are wireless or Bluetooth monitors that the patient doesn't have to text anything. It just goes straight to a platform. So it takes that middle step out. We chose text messaging also because it's not app-based. So you don't necessarily need a smartphone, although most people have those these days and have all the apps. You just need to be able to text message. but there's many different ways you could check your blood pressure and give it back to the people on the receiving end. But why do we do it? To reduce visits, to allow for closer surveillance, and we think it's convenient for the patient. I highlighted our program. There are 2 other ones that have been published that I know of. I apologize if you're on this call and you have a different sort of program that's out there. But the University of Wisconsin and Pittsburgh also have programs. They're not exactly the same. They're different in terms of who receives the blood pressure and sort of their own protocols. But having done different panels with people from both these programs, I will say it's pretty fascinating that all of us have the same outcomes pretty much. So high compliance and adherence, high patient satisfaction, similar rates of achieving the ACOG standard, reduced readmissions, emergency room and office visits, shorter length of stays, improved postpartum visit attendance, reduction in maternal morbidity, and reduction in racial disparities. And so these programs are working. I think they're especially helpful in places where people live far away from the hospital, in some of these sort of remote locations, to still be able to go home and have someone track their blood pressure. So I talked about our study, and that was just a small population, but sort of the results of the study did allow us to get buy-in from the champions at our hospital. And I said that we implemented it initially at the hospital of the University of Pennsylvania as standard of care after our study, but we've since implemented it at all 5 Penn obstetrical hospitals. And this is data from January. We review this. We actually continue to review program data monthly, but we sort of have these big stats every twice a year. You can see the patient enrollment is sort of related to just the general delivery volume of the different hospitals, but pretty consistent across the board. 85 to 90% of patients who send in at least 1 blood pressure, regardless of site. And we have a dashboard that automates from the program that lets us know. You can see again here, pretty consistent in meeting the ACOG guidelines. This is by month, but we've been pretty much in the same place. How do we get to 100% engagement? That is our goal. I'm satisfied with 86 because it's better than 0 or 30% when we were doing in-person checks. But how do we get to 100% engagement? That's something that we're still striving for, and an area of improvement. And one of the things that we did is that we teamed up with some students from the the public health school, and we interviewed patients, and we wanted to learn sort of what was associated with patients who were non-users, who didn't respond at all. Who were the super users who sent in 2 blood pressures every single day that we asked them? Because we want to be able, we overcame some barriers, but we want to be able to target all the patients and make sure that we get the information, since all these patients were high risk. And we learned through these patient interviews that the general sense of importance of blood pressure follow-up actually was low priority for all the patients. And so it didn't matter how much we told them, you're really sick, you're at risk of this is why it's so important to check your blood pressure. That wasn't really correlated with the patients who sent them in versus didn't send them in. And what I found was interesting, and I think just highlights the general system, is that the most important factor was how difficult was it to transition into the postpartum period. And you can see the super users and the moderate users, it was an easy transition out of the hospital, and they had support. And those who didn't use it just were really struggling. And I think this just highlights the need, not just for hypertension, but to focus on the 4th trimester and make it easier for our patients to transition out of the hospital and give them the support that they need, because it probably impacts not just getting blood pressures, but their mental health, their breastfeeding success, all the other issues that arise in the postpartum period. And so I just thought that was really fascinating and something important to share with sort of the general group. I realize I speak really fast and I'm cruising through this. So we have scaled outside of the Penn system. We received a Merck for Mothers grant through the City of Philadelphia Department of Public Health. We have implemented this at all the OB hospitals in the city of Philadelphia, understanding that hypertensive disorders are a major contributor, amongst other things, to maternal morbidity and mortality in our city. And so we've successfully done it outside of our system through the SAVE program. And again, I told you, different hospitals are implementing it in different ways, but on the patient end, it's exactly the same. And if anyone is interested in hearing more about the program, we have actually spoken with some people from Georgia. This is the website where you can learn more information about our program. And there's an opportunity to sort of set up a meeting with us at no cost. That we're here just to improve patient care and learn more about our program and figure out ways to potentially implement this at your hospital if it's something that you're considering. A big barrier to implementing, like I said before, is cost. We've met with a lot of hospitals and other practices who are interested, and at the end of the day, there is a cost on the back end. And how do we sustain this program? Again, like I said before, we started with grants. We continue to apply for grants to research more about this, but it's not for us. Unfortunately, our department helps pay for it, but that's not feasible in a lot of different places. And so now that this is pretty seamless here, we've sort of shifted our focus to focus with the payers and really push for reimbursement. So we have a lot of discussions with the private payers and the public insurances about getting reimbursed for remote blood pressure monitoring after delivery. There are telehealth codes for remote device monitoring. Some require telephone or televideo visits. Some are based on the number of blood pressures you receive within a time frame. And we've sort of worked with the payers to figure out how to optimize sort of the reimbursement policies. And we've actually collaborated with some of the payers to do cost analyses. Does short-term improvement in care, translate to long-term health benefits and save money for some of the patient, for the insurances over the course of the year postpartum or afterwards. And we've actually have some promising data that hopefully will be published soon about the long-term health benefits within the first 6 months and year after delivery associated with just enrolling in such a program for 10 days after delivery. So both short and long-term benefits seem to happen. And how, I think getting paid for this would be key, not just for us, but to help implement similar programs. They don't necessarily have to be the exact Heart Safe Motherhood program that we designed, but to be able to do remote monitoring in other places, since it does seem to be beneficial in terms of getting the blood pressure information and just making it more patient-centered. Like I said, I talked really fast. That's my last slide. Thank you. And hopefully you guys, looks like there's a bunch of questions. Hopefully we can spend some time chatting further.